A very good morning to all of you and welcome to the GMO Academic Cow program. Today's topic is on anemia, the enemy of energy. So let me introduce today's lecturer, Dr. Nadeeshani Ediriwickrama. She is consultant clinical hematologist attached to Teaching Hospital Kurunegala. Dr. Ediriwickrama obtained MBBS from the Faculty of Medicine, Colombo in 2007, followed by Diploma in Clinical Hematology in 2014 and MD in Clinical Hematology in 2016 from the PGIM, Colombo. She completed overseas training at the King's College Hospital, London in 2017 to 18, and she has board certified as consultant hematologist in 2018. Dr. Ediriwickrama has worked as a consultant clinical hematologist at NHSL, LRH and Castle Hospital for Women, and currently serving as the clinical hematologist at Teaching Hospital Kurunegala. Her research interests are on thrombosis and hemostasis myeloma. So let me warmly welcome Dr. Nadeeshani Ediriwickrama to a presentation.
Thank you, Dr. Charuni, for that kind introduction. And also I would like to thank GMOA for inviting me to deliver a talk on anemia. It's a sort of a wide topic, so let me try to sort of concise my talk to 1 hour and to enlighten you on anemia. So let's have a look at what anemia is. It's defined as reduction in hemoglobin concentration, which is given as normal for the age and sex. So WHO has put on some cutoff values for the according to the sex categories. For male, it is said that anything below 13 grams per deciliter is called anemia. For a female, it's 12 grams per deciliter, and for a child, it's 11.5 grams per deciliter. However, among Asian population, these values or normal levels for cutoff levels for anemia are a little bit lower. Among Sri Lankan population, unfortunately, we don't have population-based studies to develop or to put up our own values to define anemia. So we have to go by these values for the time being. Okay, so let's first have a look at how to classify anemias. This is a sort of a popular classification. Here what we do is we classify anemias according to the size of the red cell. So what we would do as the first thing, if you think that the patient is having anemia, to do a full blood count. In the full blood count you would get MCV. So according to the MCV you can categorize anemias as into hypochromic microcytic, normochromic normocytic, or as macrocytic anemias. So examples for hypochromic microcytic anemias are iron deficiency, thalassemia, and also anemia of chronic disease can also have hypochromic microcytic indices. So according to this classification, next they have what you should do is reticulocyte count. If retic is low, usually you can think that is iron deficiency. If it is high, usually it's thalassemia trait. But this is quite an arbitrary classification, because sometimes in iron deficiency also in it's an exemption. Can get high retic count if the patient is having chronic bleeding. So iron deficiency occurred, if it is occurred because of bleeding, they can get high retic count. So that's an exception. So when you talk about normochromic normocytic anemias, anemia that occur because of chronic diseases, inflammation, liver renal disease, or else because of any bone marrow pathology, can get normochromic normocytic anemia, and also it will have low retic count. If there's hemolysis or bleeding, they can get still can get normochromic normocytic anemias with a high retic count. So classical examples for macrocytic anemias are B12 folate deficiency. Apart from that, chronic liver cell disease, alcohol consumption, chronic alcohol consumption, hypothyroidism, certain medications like methotrexate, cotrimoxazole, which are antifolate drugs, can cause macrocytic anemias. Spuriously, you can get macrocytic anemias when there is high retic count. For example, if there's a massive blood loss or ongoing severe hemolysis, you get plenty of reticulocytes in the circulation. Reticulocytes are the immature red cells releasing from the bone marrow. So they are larger in cell size. Therefore, the machine count the MCV as a higher value. So you will get high MCV. In other words, spuriously, it's a macrocytic anemia that you are dealing with if the patient is having a high reticulocyte count. Okay, so for the ease of the flow of this presentation, I have classified or I have put up this classification according to the cause of anemia. So first, red cells are produced in the bone marrow. So if there is some insult in the bone marrow, you will definitely get anemia, but not only anemia, but also rest of the cell lines also can get affected. So any bone marrow failure syndrome, if there's a marrow infiltration by a hematological or a non-hematological malignancy, or if there's a reduced production because of other reasons, you can get anemia. The next, the other cause I would like to say, if you have the factory is fine, the marrow is fine, but you don't have enough raw materials. That is what happens in nutritional anemias. The main nutrients that we need is B12, folate and iron. Apart from that, all minerals like zinc, copper is also needed for a proper hemopoiesis. Then so you are producing well, and you have enough raw materials, but you are losing. If you are losing also, you will end up in getting anemia. Similarly, if the patient is having a large spleen, for example, classical example is chronic liver cell disease, and sometimes other diseases like rare diseases like sarcoidosis, leishmaniasis, all can cause splenic enlargement. Spleen is an organ where red cells or the blood tend to pool inside. So if there's large spleen, then you will end up in having not only anemia but also with pancytopenia. And finally, if there's a peripheral destruction of red cells, again you will end up in anemia. So these are the broad categories that I want to discuss. So just a few words about marrow failures. First I want to discuss a little bit about aplastic anemia, because each one of these diseases are separate lectures, so I don't want to go into details. I will just briefly tell you what these diseases are. So aplastic anemias can be acquired or congenital. So in adults, what you usually see is this acquired aplastic anemia which has an immune pathology. Compared to that, inherited ones are usually seen among kids, and they are Fanconi anemia, Diamond-Blackfan, Shwachman-Diamond. There are lots of congenital aplastic anemias or marrow failure syndromes. So what happens in acquired aplastic anemia, which is the commonest aplastic anemias that we see, this is what happens. The marrow gets empty. So here you can see this is a bone marrow biopsy, a trifine biopsy actually, and it's all these. There are here and there you can see some hemopoietic cells, but most of the time, more than 80% of the marrow spaces are empty and filled with fat spaces. So that's what happens in aplastic anemia. Okay, and myelodysplastic syndrome, another example for marrow failure syndrome. So what happens there is, so marrow is producing, marrow is not empty, but whatever produced in the marrow is not really effective. They are not normal, they are not functional. So in this blood picture you can see there are 4 neutrophils which has quite abnormal nuclei. So their segmentation is abnormal, and also the granulation is also abnormal. So this is what you see in the peripheral blood in myelodysplastic syndrome. Sometimes myelodysplastic syndrome can only present with anemia, but can lead to bicytopenia or pancytopenia depending on the cell lines affected and the severity of the disease. So that is another example for marrow failure syndrome. And marrow fibrosis. So marrow fibrosis can be primary or it can be secondary to radiation or autoimmune background, anything. So this is what we see in marrow fibrosis. The entire marrow spaces are replaced by collagen. So you can see this fibrous like tissue instead of the hemopoietic tissue in the marrow. So that's what happens. So also finally I would like to tell that lack of erythropoietin drive also contribute towards a marrow failure, because erythropoietin is the driving hormone to produce red cells. So example, in chronic kidney disease there's lack of erythropoietin drive leading to lesser production. Okay. Right. So these are few examples for marrow failure pathologies in marrow. Not only that, I have told you before, there can be marrow infiltration by any other hematological or non-hematological malignancies leading to anemias and cytopenias. Okay. This is, I think, this is going to be the major component of my presentation, the nutritional anemias, because the commonest causes of anemia among our population is because of nutritional deficiencies. Of them, iron deficiency is the most predominantly found cause. Okay, so let's first have a look at iron deficiency. So why do we need iron? So you all know, if I were to take you back to your undergraduate staff, you know this is a hemoglobin molecule which consists of 4 globin chains, and inside each there are heme molecules. So heme is consistent of iron. So this iron is needed for oxygen carrying. So you all know, so we need iron for a proper oxygen carrying capacity. Not only that, I want to highlight the fact that the cytochrome enzyme system also needs iron for their action. So if you can remember, in mitochondria you have cytochrome enzymes which contributes towards producing ATP. So when patients are iron deficient, so they will deplete their ATP production or ATP stores. So that is why most of the patients develop symptoms even before they become anemic. So they will complain of tiredness and all because of lack of ATP. So how are we going to take iron? So iron is coming from our food. So it can be an animal-based food or a plant-based food. So when you talk about animal-based food, so usually iron is usually found in red meat, and apart from that, it is said that clams, shrimp, eggs, all other meats and fish will contain iron in some amount. And plant-based food also contain iron, like green leaves, legumes, grains, and broccoli. They say it has lots of iron. Pumpkin seeds, all will contain lots of iron. Okay, let's see how this iron, once you take, it's going to get absorbed to our body. So iron is absorbed, but mainly from the latter part of the stomach and the first parts of the duodenum. So what happens at the cellular level is, so here we see the heme iron which is coming from the animal sources, and there's non-heme iron which is coming from the plant sources. There are two types of iron. So this non-heme iron will directly get absorbed via this transporter, and its bioavailability is higher compared to non-heme iron, because non-heme iron has to be converted to ferrous in order for it to get absorbed. Therefore, it's important to highlight the fact that the quality of iron is different in animal-based food as well as compared to plant-based food, and that is why we vegetarian people who are not consuming meat-based products there's more prevalence or more chance for them to get iron deficiency compared to who eat meat. So once they are absorbed, they will be transported via this ferroportin 1 channel to the bloodstream. Okay? So in the bloodstream, it will be it will be bound to transferrin and will be transported to this reticular endothelial system for production of for storing as well as for production of red cells. Once the liver is saturated with iron, when liver thinks, or when the body system thinks that now look, we have enough iron, liver will secrete hepcidin molecule and it will inhibit this ferroportin. So thereby the iron absorption will be inhibited. So that's an important mechanism for in our body to sort of control iron absorption. Okay, and some amount of iron that is absorbed will remain inside this mucosal cell, and when the cell is shed, this amount of iron will be shed along with, or will be expelled along with stools. So this is the only physiological mechanism where we have of physiological mechanism to excrete iron. Okay. All right. So what are the factors that will affect iron absorption? So iron absorption will be increased by acidic media. So if I were to go back to the previous slide, so here you can see the ferric needs to be converted to ferrous form, and the conversion will occur at the presence of an acidic media. So this conversion is necessary for iron to get absorbed, particularly for iron that is coming from the plant-based diet. So a gastric media is quite important for iron absorption. That's why we advise patients to take vitamin C along with iron. And these factors will decrease the. Also important for you to know phytates. So phytates are found in legumes. So I told you legumes and grains and legumes will contain iron at the same phytates as well, which will impair iron absorption. So that is another reason why this iron coming from plant-based diet is a bit tricky, and it's not that of good quality. Phosphates, calciums, all compete via same channel for it to get absorbed. Therefore, at the presence of calcium and phosphate, iron absorption will be reduced. Tannate is found in tea and coffee. It will also impair absorption of iron. So that's why some of our people, they have a habit to drink a tea after meal. So that's a bad habit that will impair iron absorption, that amount of iron that they have taken from that particular food. Okay. So in contrast, for patients who are iron overloaded, example in thalassemia major, we advise them to take a cup of tea after a meal to reduce the iron absorption. Alright, so milk, alkaline pH, all will reduce the iron absorption. So these are the causes for iron deficiency. So there can be increased demand, like in physiological status like pregnancy and childhood. And particularly when it comes to pregnancy, we all know that we give prophylactically from MOHs. Prophylactically, our mothers are given iron supplements. And most of the iron is transferred to the fetus during the third trimester. Therefore, it's important for them to store lots of iron, or not to get iron deficient when they are pregnant. And in children also, because of their growing age, there's a high demand for iron. Literally, it's said that children do not have iron stores up until they are 4 to 5 years of age. So whatever they eat will be consumed. So both of the categories are at high risk of getting iron deficiency because of high demand. Also, when there's blood loss like menorrhagia, PR lead, inflammatory bowel disease, GI malignancies, or any kind of blood loss from the body can contribute to iron deficiency. If I've told you that vegetarian diet or vegan diet also can lead to iron deficiency because of low quality iron that they are taking. If there's any pathology in the stomach and the first parts of the duodenum, then that will lead to poor absorption. Also, I've told you what the factors that can affect poor absorption. If there are any factors like that, like caffeine consumption, then again they can have poor absorption. So these are the causes for iron deficiency. So I briefly touched on the symptoms. So these are the particular symptoms that they get in anemia: fatigue, palpitations, poor focus, restless leg syndrome, particularly seen in iron deficiency, headache, weakness, shortness of breath. Of course, occurs when they are particularly anemic, but rest of the things like weakness, poor focus can occur when they are not even they become anemic because of iron deficiency itself. And restless leg syndrome is not that uncommon. If you dig into the history, patients will come up with that symptom where they can't keep their legs in position. They want to either change the positions of the leg, or they want to walk around, and basically legs are quite restless. So that is a common symptom that patients will come up. Okay, these are the signs. They can be glossitis, palo, angular stomatitis, chloilonychia, which you all know. Okay, so how are we going to investigate anemia? So this blood picture, so first thing we would do is a full blood count, where you would look at the hemoglobin, which is low, and then you would look at the MCV and MCH. Again, here it is low, and this is a full blood count of iron deficiency. Here red cell count is also low, and if you pay your attention, red cell distribution width, or RDW, is high in iron deficiency. So let's have a look at what this RDW is. So it's a red cell distribution width. If you measure each of red cells and put it the size in a Gaussian in a curve, I mean, if you plot it, you will get a Gaussian curve. So this is a normal red cell distribution width, and this is a normal red cells that you can see in a normal person. You can see the red cell size and the shapes are uniformic. So then you get a normal RDW. Whereas in iron deficiency, you will get different shapes and sizes of cells, which we call anisocytosis, and because of that you will get higher RDW. It's actually the standard deviation or the coefficient of variance of this Gaussian curve. So this is a normal blood smear. Here you can see the monomorphic red cells. Compared to that, this is the blood film of an iron deficiency. You can see hypomicrocells, some polychromatic cells, pencil cells, what we call anisocytosis. So that can lead to high RDW. So the main differential for iron deficiency is Thaltrate. So in Thaltrate also you would see anemia with hypochromic microcytic indices, but compared to iron deficiency, red cell count is normal or high, and the RDW is more or less normal. So let's have a look at why that happens. So here this is a blood film of a Thaltrate, but here you can see the red cells, even though they are hypochromic microcytic, you can see some teardrop cells, target cells, but despite all, the red cell size is more or less uniformic. Therefore, you get normal RDW in Thaltrate compared to higher RDW in iron deficiency. Okay. So after full blood count and blood picture, these are if you suspect, so by doing full blood count and blood picture, you can sort of narrow down your differentials, and if you still suspect iron deficiency, these are the investigations that you should go for. And retic count is important. I told you even before, if there's a bleed which is the cause for iron deficiency, the retic count will be high compared, so that therefore retic count has to be done. Serum ferritin, now these days it's a sort of a gold standard test to detect iron stores. However, it's important for you to remember that ferritin can be falsely elevated if there's a background inflammation or infection or any other trauma or surgery, any insult to the body. Apart from that, rarely ferritin can be elevated if the reticular endothelial system is damaged. For example, if there's liver cell necrosis, hepatitis, marrow necrosis, splenic infarction, because these are the organs where the iron is stored. So if there's damage to these organs, iron will be expelled to the circulation, giving rise to a falsely elevated ferritin level. So this is the most important thing, infection, inflammation, because when patients come, usually patients come to you with some kind of an illness, then only you detect that they are anemic. So there's no point in doing ferritin at the same time, because you have to allow the patient or allow the infection to settle, then only you should go for the ferritin levels. Okay. Okay, so if you really can't figure, ideally speaking, along with ferritin, you have to do iron studies as well. So iron studies comprises of serum iron, total iron binding capacity, and iron saturation. But in our usual practice, we don't really do these things because it's not freely available in the government sector. actually because of the lack of resources. So if you can't figure out or can't really come to a conclusion just by doing ferritin, then there's a value in doing iron studies. So in iron deficiency, serum iron will be low, iron binding capacity will be high, saturation will be low. We take 20 as the cutoff for iron deficiency. So in the absence of these studies, even a trial of iron therapy can be considered as an investigation, because you can give the patient little iron and maybe relieve the patient maybe in 2 weeks or 1 month, and if there's an increment after taking proper dose at proper time, then you can retrospectively diagnose iron deficiency. So once you make the diagnosis of iron deficiency, if you really, if there's no obvious cause for that, then you have to investigate for a cause by doing maybe stool for blood, upper GI, lower GI, UFR, depending on the facts in the history that you think is important. You have to investigate, because particularly females, because of menstrual loss and all, they tend to get iron deficiency it's quite common among our female population. But if a male present to you with an iron deficiency, and if the diet is adequate, certainly you have to dig into and look for a possible cause. You might be missing a malignancy otherwise. Alright, so how are you going to manage? So there are two arms of managing. First is to treat the etiology, and also then to replace iron. And if the etiology or if the cause for iron deficiency is there, however much you replace iron, there's no point, because they will recurrently get iron deficiency. I think I have dealt with the causes of iron deficiency. Therefore, you have to address the cause and correct the cause. So there are two ways in replacing iron. Either you can replace it orally, which is the commonly used method, or rarely we can use parenteral methods, or IV iron also, to replace iron. So these are few examples of oral iron. So usually elemental iron of 100 to 200 per day is adequate. There are so many preparations in market. So it has to be taken on empty stomach, ideally in the mornings, because in the mornings hepcidin levels are lower, therefore iron absorption is higher in mornings. And when there's, I told you there can be lots of factors can affect iron absorption, therefore it's advised to take on empty stomach. Okay, once daily dose is adequate, and usually we prescribe vitamin C and folic acid as well along with. However, the commercial preparations available in the market usually do have this vitamin C and folic acid incorporated into it. The increment that we expect if the patient's compliance is good is 2 grams per deciliter in 3 weeks' time. And in our practice, we try to avoid blood transfusions as much as possible, because there's a quick rise in hemoglobin after maybe a couple of weeks, and they become asymptomatic, and blood is considered as sort of a dangerous drug, because it can cause reactions and all these unnecessary problems. Therefore, unless it's really necessary and patients are quite symptomatic, we don't give blood. And iron should be continued for about 4 to 6 months altogether, or 3 months after hemoglobin becoming normal, to replenish stores. So patients may complain of constipation, gastric irritation, sometimes diarrhea, and almost all will get black stool. So we have to warn them not to be scared. Because of these tablets, they can get black stools. Okay. So moving on to IV iron. So it's important for you to know the indications for IV iron. Usually the most common indication is a third trimester in pregnancy, because I told you most of the amount of iron is transferred to the fetus during the third trimester. In the third trimester, if the mother is still iron deficient, we consider giving IV iron to replenish stores immediately. And if the patient can't tolerate, if there's absorption issues like in celiac disease or inflammatory bowel disease, then of course we tend to give them IV iron. And in CKD, where there's lots of hepcidin are secreted to the circulation, oral iron absorption is very poor. Therefore, we tend to give IV iron. So the side effects are, it's a costly option compared to oral iron, and it can cause reactions. Therefore, that has to be borne in mind. Okay, so this is this recommended follow-up. Full blood count should be done monthly, and once iron deficiency is treated also, you really can't wipe off your hands. You have to check at least 6 monthly full blood counts to check whether the patient will get iron deficiency again. Okay. So let's move on to megaloblastic anemia, which is the next most commonest cause for anemia among our population. It's increasingly becoming more commoner than in past. Okay, so why do we need B12 and folate? So in this complex diagram shows that B12 and folate is necessary for conversion of homocysteine to methionine. This is the pathway where they make purines and pyrimidines. So purines and pyrimidines are the sort of backbone for DNA production. So DNA and RNA. So if B12 and folate are depleted, DNA production will be impaired. So therefore, they can get not only anemia but also pancytopenia. All these regenerating cells can get affected. Therefore, they can present with subfertility. And these byproducts are important in myelin sheath formation. So if there's a B12 folate deficiency, particularly B12 deficiency, there will be poor myelination of neurons, leading to subacute combined degeneration of the cord, leading to peripheral neuropathy. And you all know folate deficiency during first trimester of pregnancy can lead to neural tube defects. Okay. So this is the blood film of a B12 folate deficiency. You get oval macrocytes, okay, teardrop cells, and here you can see Howell Jolly body. This is the abnormally formed DNA fragments, and here you can see this abnormal neutrophil which has so many lobation in the nuclei. So what we call hypersegmented nuclei. So these are the typical features of a in the blood film of a megaloblastic blood patient in megaloblastic anemia. So how are we going to get B12 and folate? Again, it's coming to our body from our food. So B12 is found only in animal-based food. So vegans, that's why the vegans tend to get megaloblastic anemias quite often. So it's found in all milk, meat, fish and all animal-based products. Folate is found usually in leaves and greens and grains. So these are the folate sources. Okay, so let's have a look at how B12 is absorbed. It's a complex process compared to the iron absorption process, and it starts at the mouth. So it starts at the mouth, the B12 bound to a component called R factor and comes to the stomach, and in the stomach it binds with intrinsic factor which is secreted by parietal cells. So once it's bound to intrinsic, so for this conversion or this to happen, the stomach needs to be in the acidic media. So once it's bound to intrinsic factor, it goes to the duodenum, and where the media get alkaline, and then at the level of ileum, it's taken up by the ileal mucosal cells and will be taken up by the bloodstream afterwards. So the absorption pathway involves mouth, stomach and bile, pancreas, as well as up to the ileum. So it's a complex process which can be disturbed at any point. Okay, so these are the causes for megaloblastic anemia. So B12 deficiency can occur because of malabsorption. So malabsorption can occur at any point. As I told you, it can be at the level of stomach or down the line up to the ileum. So if there's any inflammatory bowel disease and pernicious anemia, that is, if you can remind your undergraduate knowledge, get back to your pernicious anemia is a condition where you have to develop antibodies against parietal cells or intrinsic factor antibodies. So either way, it can impair B12 absorption. So if a patient is vegan, or if there's any surgical procedure involving any down the line up to the ileum, maybe ileal resection or gastrectomy, bariatric surgeries, all can lead to B12 deficiency. And folate deficiency can occur because of poor dietary intake. Particularly, it's common among elderly people who don't have a proper nutrition, and alcoholics who ignore their nutrition. It's common. And when there's increased demand, as in hemolysis or in pregnancy, exfoliative dermatitis, again folate deficiency may occur. And malabsorption and antifolate drugs, again like methotrexate is a classical example, can lead to folate deficiency. Okay. So again, investigations are more or less the same. Basic investigations would be full blood count, blood picture, retic. Retic can be increased in B12 folate deficiency because of ineffective erythropoiesis. Okay, and in developed countries, so the recommendation is to do B12 and folate levels as well. But we hardly do them because of lack of resources. And in our setup, it is much cheaper to give a trial of B12 folate and to see whether there's an improvement rather than doing B12 and folate levels. Therefore, in practice, we tend to omit this because of lack of resources. And also B12 levels can be very can leads to, subjective to a lot of interferences. Like after a meal, it can go up; in pregnancy, can go up; in infection, it can go up. So therefore, the cost that you sort of bear to do B12 levels is not that cost effective. Therefore, we tend not to do it in our day-to-day practice. And if you strongly suspect pernicious anemia, you might have to do an upper GI and take biopsies. And you can also do intrinsic factor antibody or antiparietal cell antibody to confirm the diagnosis of pernicious anemia. So how are you going to manage B12 folate deficiency? B12 can be given as IM injections or oral. IM injections can be in the form of hydroxycobalamin or cyanocobalamin, and has to be given usually given 6 doses within 2 weeks. And orally you can get cyanocobalamin, which usually we give for about 2 weeks, and then assess the response and decide whether they need more, how the duration of the treatment. And folic acid usually is given in 5 milligrams for the deficient patient for 4 months. And also dietary modifications are equally important in the management. Right. So that is about B12 folate deficiency, and I would like to touch upon anemia of chronic disease as well, because it's quite commonly seen. You must be seeing in our blood films also we are reporting anemia of chronic disease, and elderly patients who are having all these non-communicable diseases are almost always having anemia of chronic disease. So what happens in anemia of chronic disease is, I hope you can remember the hepcidin molecule that I mentioned when I was discussing the iron absorption. So when the liver is saturated with iron stores, it will secrete hepcidin. Then this ferroportin transporter will stop iron absorption. This hepcidin molecule will be secreted as an acute phase reactant in inflammatory conditions. So thereby in inflammatory conditions, this hepcidin will be secreted more and ferroportin will get inhibited. So ferroportin is not only found in the gut, but also it's found in iron storing organs like spleen and liver. And to release iron also, this ferroportin transport is important. So in inflammation, not only the absorption but also the available iron will also not be released from the stores. So the iron absorption will be impaired, iron release will be impaired. So this is what happens in chronic inflammatory conditions. So not only that, that's one mechanism. poor dietary intakes. All these ill patients, I mean, if they are not well, they don't take a proper diet, which can contribute towards nutritional deficiencies as well. So reduce erythropoietin secretion, particularly seen in CKD, and reduce lifespan. Usually, the usual lifespan of a red cell is 120 days, but in chronic inflammatory conditions, it reduces maybe up to 80 days. So then that is also a reason why they get anemia in inflammatory or any chronic diseases. So these it's a complex pathology. So these are the reasons for the anemia of chronic disease. Sometimes some of these anemias we can sort of give some erythropoietin and treat, but not all the time. Okay? So these are the investigations, usually full blood count, blood picture, and we do ferritin. Usually ferritin is high in inflammatory conditions. Therefore, we do iron studies as well to come up to conclude or to confirm the diagnosis. Okay, so I have discussed briefly the marrow failure syndromes or marrow failure problems with the bone marrow, and I have discussed extensively nutritional deficiencies, and now I have talked about blood loss and splenic sequestration. Finally, I would like to talk a bit on destructive causes, or how red cells can get destroyed once they are produced. Okay, so these are the causes, broad classification of the causes for red cell destruction. In other words, we call them hemolytic anemias. Immune hemolysis is the commonest hemolytic anemia that we see among our day-to-day practice. It can be a warm autoimmune, cold autoimmune, or a mixed immune hemolysis. So what happens there is, so this is warm type autoimmune hemolysis. You get spherocytes and polychromatic cells. Okay, so what happens here is IgG antibodies will coat red cells, and when they are passing through this reticular endothelial system, it will be identified as an abnormal red cell and will be destroyed. It's an extravascular hemolysis. Okay, so as for hemolytic markers, DAT, LDH, bilirubin, haptoglobin, or those are the things that we will do. That will show IgG antibodies. These are the IgG antibodies, and retic will be high, bilirubin, the indirect component will be high, LDH will be high. In contrast, what happens in cold autoimmune hemolysis is IgM comes to the play. So IgM has 5 arms compared to the 2 arm in IgG. It has 5 arms, so it can get hold of many red cells. If one IgM molecule can get hold of many red cells, and each red cell can sort of get hold of another IgM molecule, making a red cell clump. So these are the red cell clumps that you see in the blood film. Okay, so this large red cell clump can activate complements, leading to intravascular hemolysis. Some amount of the red cells will be destroyed by extravascular hemolysis, but some will go into intravascular hemolysis. So this is a picture of extravascular hemolysis, where red cell is broken into its components inside the macrophage. Okay, so and excreted via bile and as urobilinogen via kidneys. In contrast, in intravascular hemolysis, red cells are broken inside the vessel, and the hemoglobin will be released, and hemoglobin will be excreted via kidneys. So this is actually toxic to kidneys. In intravascular hemolysis, you get hemoglobinuria, and if it goes on without proper hydration and supportive care to kidney, can end up in acute kidney injury. Okay. All right. So next, so after immune hemolysis, then I would like to touch upon microangiopathic hemolysis. So that is what we call MAHA. So these are typical 3 examples for MAHA: DIC, TTP, and HUS. So let's first have a look at what happens in DIC. So there has to have the patient has to have a background or a background disease for activation of coagulation pathway. So like sepsis, burn, massive trauma, massive blood loss, or massive transfusion can all lead to endothelial damage, as well as a result coagulation pathway can get activated. So there can be microclot formation in the so this small arterioles and arteries, and this will lead to consumption of coagulation factors as well as platelets. So this if you do investigations, you would see thrombocytopenia and elevated PT and APTT. So at the same, once the coagulation clot formation is initiated, the clot lysis or fibrinolytic pathways also get activated. Thereby you will find high D dimers in DIC. So there will be, because of microvascular thrombosis, there can be multi-organ ischemia, and thereby it can lead to multi-organ failure. At the same time, because of activation of fibrinolysis, there can be bleeding from here and there, like puncture site bleeding. So, so this is the pathophysiology. So what you see in the blood film is this. So when these red cells are passing through these microclots, it can break. So will giving rise to this sort of red cell fragmentation in the blood film. Okay. So next we'll have a look at what happens in TTP. The pathophysiology, so what you see in the blood film is red cell fragmentation like in DIC, but the pathophysiology is entirely different. What happens in TTP is von Willebrand factors are in large multimer forms which are secreted from the vessel wall endothelial cells. There's a protein or an enzyme called ADAMTS13 which is supposed to cleave these large von Willebrand factors into small pieces for them to get into the circulation like this. Okay, so when they are cut, the platelet binding sites will be hidden inside this von Willebrand factor. So von Willebrand factor will on its own will not bind to these platelets unless they are activated. So that's the basic hemostatic, physiological status. But what happens in TTP, there will be either there is a deficiency in ADAMTS13 or there is an antibody to ADAMTS13. So in any way, the ADAMTS13 is not working. So therefore these large multimers will be expelled into the circulation from the endothelial cells, and the platelet binding sites are exposed in this large von Willebrand factor multimers. So the platelet will bind to this multimers and will form platelet clots. And the coagulation system is not involved in this pathophysiology, only the platelets are involved. When red cells are passing through these minor clots, again it can be broken and giving rise to this sort of a blood film. So I'm not going to go into detail of these diseases because it comprises of entire one lecture. So I'm just touching upon and telling you what these are. And HUS is another example for MAHA. Again, more or less similar. By looking at it, it may look like TTP because kidneys can get involved, but the pathophysiology is again different because there are two types of HUS, typical and atypical. Typical HUS occurs following a E. coli diarrhea, not in all but sometimes. And atypical HUS is the one which we actually come across quite often. It occurs because of activation of complements. Again, platelet clots can form here and there and red cell fragmentation occur. Coagulation pathway is not involved in HUS as well. So you will get normal PTA, PTT. If you do a full blood count, you will see anemia and thrombocytopenia. Hemolytic markers can go up in any of these hemolytic conditions. Retic, LDH, indirect bilirubin component can go up. So this is what happens in HUS. So predominantly there will be renal involvement compared to TTP. So TTP there will be mild elevation of creatinine, but in HUS most of the time it will end up in requiring dialysis. Right. So these are the classical three examples of microangiopathic hemolysis, and there can be hemolysis due to red cell membrane disorders, enzyme disorders, or problems with hemoglobin. So classical example for membrane disorder is hereditary spherocytosis. There can be hereditary eleptocytosis, pyropoikilocytosis, which are quite rare. Therefore, I thought I should not touch on that. Instead, I will just briefly tell what hereditary spherocytosis is. So again, if you can recall your undergraduate memory, so in the red cell membrane, you have these transmembrane proteins, and underneath that, there are cytoskeletal proteins, which helps to maintain this biconcave disc shape of the red cell. So what happens in HS or heterospherocytosis? These cytoskeletal proteins, or sometimes it's transmembrane proteins, are abnormal. Therefore, red cell will find it difficult to maintain its globular shape. Okay, so when these red cells are passing through the reticuloendothelial system, those will be identified as abnormal cells and will be engulfed by macrophages, giving rise to extravascular hemolysis. Okay, so this is the blood film. Here you can see there are lots of spherocytes, globular shaped cells, which has lost the biconcave disc shaped cells. Okay. Right. So moving on to enzyme disorders, again I am going to talk about G6PD deficiency, which is the commonest we see among our population. Apart from that, there can be like something like pyruvate kinase deficiency, which is quite rare. So let's have a look at what G6PD deficiency is. So G6PD, or glucose 6-phosphate dehydrogenase, is an enzyme which is necessary for NADPH formation. NADPH is necessary to maintain an adequate glutathione resource. So if you can remember, you identify what glutathione is. It's an antioxidant, and this is very important for the survival of red cells, because red cells, the function of the red cell is to carry oxygen. So red cells are highly likely to get oxidative damage. So glutathione is necessary to repair this oxidative damage of red cells. So when G6PD is absent, glutathione stores will be absent, subjecting red cells to oxidative damage of the red cell membrane as well as hemoglobin. Okay, so because of the oxidative damage, the red cell, the hemoglobin will get denatured, the red cell membrane proteins will get denatured. So these abnormal cells will be identified by the macrophages when they are circulating through the reticuloendothelial system, and these abnormal parts will be bitten or will be engulfed by the macrophages, giving rise to bite cells, and this denatured hemoglobin will go to one side and gives rise to blister cells. So if you go through blood pictures, you might see, we mentioned that blister cells and bite cells were seen. So these are the blister cells. So there's a blister-like thing here with intact membrane because of the denatured hemoglobin. So once this part is eaten up by the macrophages, you will end up in having a bite cell. Okay. In G6PD deficiency, not only this extravascular part of hemolysis, but also intravascular hemolysis could also occur because of the damage to the red cell. So therefore, it's very important to know that if patient is presenting with G6PD deficiency, they can get hemoglobinuria and AKI as a result. Okay. Finally, I would like to just touch on thalassemia syndromes. So this is again will comprise a separate lecture, but just to touch on, this is a blood film of a thalassemia. It could be a major or intermediate, which consists of lots of hypochromic microcytic red cells, NRBC, and targets, irregularly contracted cells, partial hemoglobinized cells. So what happens there is the problem lies within the hemoglobin. So it can be because of either alpha gene mutations or beta gene mutations. So because of that, there will be abnormal hemoglobinization, and which will lead to premature destruction of red cells inside the bone marrow itself, leading to ineffective erythropoiesis, and that is also a sort of a hemolysis, and therefore the patient will remain anemic all the time, and there is a component of ineffective erythropoiesis also. So bone marrow is producing, but the outcome is poor. So the patients will be sort of transfusion dependent, and because of that, as well as because of increased iron absorption from the gut, they will end up in having iron overload. So we'll be treating them for iron overload as well. We nowadays, because of regular transfusion programs, we hardly see this expansion of bone marrow spaces and all the rest of the complications are much more lesser compared to the good old days. So this is what happens in roughly what happens in thalassemia syndromes. So this brings to the end of my presentation. So in summary, what I want to tell you is causes for anemia is quite wider, and basic investigations like full blood count, blood picture, retic can lead to a sort of a directive towards a diagnosis, and to differentiate whether it's nutritional, hemolytic, or any other baropathology or any so on. And because nutritional anemias are the commonest, it's important not to miss that, and it can be easily manageable and preventable. So that is the message I want to give you, and thank you so much for listening and participating.
So let's meet up in 2 weeks' time with a new topic. And let me again thank Dr. Nadeeshani Ediriwickrama for today's lecture. Thank you so much for the participants for joining us.